In this presentation, we will discuss the systemic clinical approach to respiratory system case presentation format. This session covers history taking, general examination, respiratory system examination, and formulation of final clinical diagnosis. First, presenting complaints. Presenting complaints include cough, expectoration, chest pain, hemoptysis, dyspnea, wheeze, and fever. These are most common presenting symptoms in respiratory diseases, and each symptom should be evaluated systemically to identify underlying pathology. History of cough includes duration, whether the cough is dry or productive, postural or diurnal variation, aggravating factors, relieving factors, and cough syncope. While evaluating cough, duration helps to categorize it as acute, subacute, or chronic. Nature of cough and associated triggers provide clues to underlying disease. Expectoration history includes onset and duration, quantity, amount per day, diurnal or seasonal variation, color, consistency, smell, and whether the sputum is blood-stained or not. These features provide important diagnostic clues. Large amount of purulent sputum may suggest bronchiectasis, while blood-stained sputum may occur in tuberculosis or malignancy. History of chest pain includes site, onset, duration, severity, pleuritic or non-pleuritic nature, radiation, progression, aggravating and relieving factors, and associated symptoms such as nausea, vomiting. In respiratory diseases, chest pain is often pleuritic and worsens with inspiration or coughing. History of hemoptysis includes duration, number of episodes, whether blood is fresh or altered, presence of rank blood or blood-stained sputum, and amount and severity, and also whether it is associated with sputum or food particles to differentiate it from hematemesis. Hemoptysis commonly occurs in conditions such as tuberculosis, bronchiectasis, lung cancer, and pulmonary infections. History of dyspnea includes onset, progression, MRC, dyspnea class, postural variation, paroxysmal nocturnal dyspnea, orthopnea and trypopnea, and dyspnea severity can be graded using MRC scale, which helps to assess functional limitation. History of wheeze includes onset, duration, progression, whether the wheeze is inspiratory or expiratory, aggravating factors, relieving factors, and allergy history. Wheeze usually indicates airway obstruction and is commonly seen in asthma and COPD. Fever. History of fever includes onset, duration, type of fever, chills or rigor, diurnal variation, night sweats, anorexia, and weight loss. Evening rise of temperature with night sweats and weight loss strongly suggests tuberculosis. Mechanical compression symptoms. Symptoms suggestive of mechanical compression includes dysphagia, hoarseness of voice, breathlessness, puffness of face, distension of neck veins, and hemoptysis. These features may suggest mechanical compression due to tumors or enlarged lymph node. Past history. In past history, we should first ask whether patient had any previous similar respiratory episodes, because this may indicate recurrent infections, asthma, or chronic lung disease. A detailed history of tuberculosis is essential. We should ask when the symptoms occurred, what was basis of diagnosis, whether sputum examination was done and sputum status. We should also ask the duration of treatment and the regimen used. It is important to determine whether treatment was complete or incomplete, and if incomplete, the reason, whether patient stopped the treatment, or the doctor discontinued it. We should ask about allergy history, which may suggest asthma or hypersensitivity disorders. History of exanthematous fevers such as measles can be associated with later respiratory complications. History of whooping cough is important, especially in childhood, as it can predispose to chronic lung disease. Next, we assess history of aspiration, which can occur in situations like anesthesia, alcohol intoxication, coma, drowning, epilepsy, or accidental foreign body aspiration. History of dental or ENT procedures such as tooth extraction or tonsillectomy may predispose to aspiration or infection. We also ask about recurrent respiratory infections, which may suggest bronchiectasis, immunodeficiency, or chronic airway disease. Associated systemic comorbidities such as hypertension, diabetes mellitus, coronary artery disease, chronic kidney disease, chronic liver disease should be noted. Finally, we ask about contact with tuberculosis patient, which increases likelihood of pulmonary tuberculosis. Next, family history. In family history, first we should inquire about consanguinity of parents, as it may be associated with certain hereditary disorders. Next, we assess sibling status, including number of siblings and their health status. The marital status of patient and health of spouse should be documented. And detailed family history of disease is very important. This includes allergy or asthma, malignancy, hypertension, diabetes mellitus, coronary artery disease or ischemic heart disease, and tuberculosis. Such information may indicate genetic predisposition or shared environmental exposure. Personal history. In personal history, we first assess diet pattern of patient. A detailed smoking history is extremely important in respiratory diseases. We should document number of cigarettes smoked per day, duration of smoking, age at which smoking started, and whether patient has stopped smoking and reason for stopping smoking. We should calculate smoking index or pack years and also inquire about any attempts to quit. Next, we ask about alcohol consumption, including duration, type of alcohol, and quantity consumed. If patient has stopped drinking, we should ask when and why. We should also ask about use of snuff, tobacco, betel nut chewing, or other substance abuse, as this may have respiratory or systemic effects. Bowel and bladder habits should be documented. Finally, sleep history should be taken, especially if obstructive sleep apnea is suspected. In such cases, the Epworth Sleepiness Scale score can be assessed. Occupational history. In occupational history, we ask about exposure to hazardous substances, dust, chemicals, or animals such as pets. We should also inquire whether patient lives near factories or mills, which may expose them to environmental pollutants. Environmental exposure plays an important role in many respiratory diseases. Treatment history. Next, we should document treatment history. We should identify the disease for which the treatment was taken, when treatment was given, where it was given, and duration of treatment. It is also important to know whether patient was regular or irregularly taking medications, and whether the treatment was supervised or unsupervised. Summary of history. After completing history, we summarize the findings. We determine whether the condition is acute or chronic, whether disease process is unilateral or bilateral. We assess whether disease is suppurative or non-suppurative. Next, we identify the likely site of pathology, which may involve lung parenchyma, pleura, or airways. Based on clinical information, we consider probable etiology. Finally, We look for any complication related to disease. General examination. General examination begins with assessing consciousness and orientation, height, weight, and BMI, and in selected cases, arm span and Murphinoid features should be assessed, particularly when Murphy syndrome is suspected. We observe whether patient is dyspneic at rest, whether there is use of accessory muscles of respiration. Next, we examine for general clinical signs including pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. When edema is present, we assess sites such as sacral, pedal, leg, or medial malleolus. We determine whether it is pitting or non-pitting, whether it is unilateral or bilateral, and whether it is painful or painless. Painful edema may suggest conditions such as cellulitis, DVT, or local skin infection. For lymphadenopathy, we examine site, commonly scalene or cervical lymph nodes. We assess number of nodes, temperature, size, shape, surface, and consistency. We also check whether nodes are mobile or fixed, whether they are matted, and whether there is any discharge. In general examination, we should also look for voice changes, which may suggest vocal cord involvement. Facial puffiness may indicate superior vena cava obstruction. Examination of neck includes looking for thyroid swelling and checking for tracheal tug, which may be seen in airway diseases. Spine should also be examined for deformities. Presence of hysterexis may indicate carbon dioxide retention and respiratory failure. Certain additional signs provide important diagnostic clues. Halitosis or foul breath is often seen in suppurative lung diseases such as lung abscess or bronchiectasis. Gynecomastia may occur due to drugs like isoniazid or digoxin or in association with bronchogenic carcinoma. Small muscle wasting of hand may indicate involvement of brachial plexus in a Pankos tumor. Another feature of Pankos tumor is Horner syndrome, which includes ptosis, meiosis, enophthalmos, anhidrosis, and loss of ciliospinal reflex. We should also assess for raised jugular venous pressure, which may indicate cardiac involvement or superior vena cava obstruction. Vital signs. Vital signs are an essential part of respiratory examination. For respiration, we record rate, pattern, and rhythm. We observe use of accessory muscles, tracheal descent, intercostal indrawing, abdominal paradox, Hoover sign, and nasal flaring. For pulse, we assess rate, rhythm, volume, and character. We also check for radioradial and radiofemoral delay, examine peripheral pulses, and assess for vessel wall thickening. Blood pressure should be measured in both upper limb and also assess for postural changes. Finally, we record temperature and measure oxygen saturation on room air, which provides an immediate assessment of oxygenation. Moving on to examination of respiratory system. After completing general examination, respiratory system examination begins with evaluation of upper respiratory tract. Nose should be examined for deviated nasal septum, nasal polyps, and turbinate hypertrophy. Because these conditions can contribute to nasal obstruction, chronic sinusitis, or postnasal drip, which may lead to cough or recurrent respiratory infections. Ear should be inspected to look for absence or presence of wax or to identify any discharge in external ear canal which may suggest infection. Examination of oral cavity is important in respiratory assessment. Oral hygiene should be assessed along with presence of halitosis, which may indicate suppurative lung diseases or poor oral hygiene. Tobacco staining should be looked as it indicates chronic tobacco use. Dental examination should identify dental caries, loss of tooth, or edentulous state because poor dental hygiene predisposes to aspiration and chronic infections. Examiner should also look for oral thrush, which may suggest immunosuppression, steroid use, or chronic illness. Tongue should be inspected for coating. Tonsils and posterior pharyngeal wall should be examined, and presence of postnasal drip should be noted as it can contribute to chronic cough and throat irritation. Respiratory system proper. First, inspection. Inspection of respiratory system begins with assessment of chest wall symmetry. If chest wall is asymmetric, several abnormalities should be looked for. Drooping of shoulder or spinal deformities such as kyphosis and scoliosis should be assessed. Scoliosis typically disappears when patient bends forward. Scapular prominence should be assessed by measuring distance between inferior angle of scapula and vertebral column. Suprascapular area, infrascapular area, spinoscapular area, supraclavicular fossa and infraclavicular fossa should be inspected carefully for any asymmetry. Bulging or fullness of chest wall may indicate pleural effusion or mass lesion. Flattening or retraction may be seen in lung fibrosis or collapse. Decrease in intercostal spaces may suggest volume loss. Intercostal indrawing indicate increased work of breathing and respiratory diseases. Chest deformities should be identified. Pectus excavatum, also known as funnel chest or cobbler's chest, is characterized by depression of sternum. Pectus carinatum, also called pigeon chest or keeled chest, is characterized by anterior protrusion of sternum and may sometimes be associated with flail chest. Other abnormalities include rib deformities, barrel-shaped chest, commonly seen in COPD, and flat chest. Position of trachea should be assessed using trail sign. Position of apical impulse should be observed. Next, movement of chest wall should be assessed, including rate, rhythm, equality of movement, and type of breathing. Skin over chest wall should also be inspected for presence of scars which may indicate previous surgery or trauma. Discharge sinuses may indicate chronic infections such as tuberculosis. Pulsations should be noted. Dilated or engorged veins over chest wall may suggest obstruction of venous drainage such as superior vena cava obstruction. Further, inspection of chest wall should look for intercostal swelling which may occur in conditions such as empyema or chest wall infections. Subcutaneous nodules may be present in metastatic disease or inflammatory conditions. Shiny skin over lower chest may be seen in empyema or hepatic abscess, where underlying inflammation stretches skin, giving it a shiny appearance. Palpation. Palpation is the next step in respiratory system examination. Position of trachea should be palpated to determine whether it is central or deviated. Apical impulse should be palpated to assess cardiac position and any displacement due to mediastinal shift. In measurements, chest circumference should be measured during inspiration and expiration to assess respiratory expansion. Measurement of chest expansion helps to identify restricted lung expansion which may be seen in pleural disease, fibrosis, or collapse. Hemithorax measurement of right and left side should be performed to detect asymmetry. Anteroposterior and transverse diameters of chest wall should be assessed. Spino-scapular distance should be measured to detect scapular prominence. Movement of chest wall should be palpated to confirm symmetry. Crowding of ribs may indicate volume loss in lung. Intercostal tenderness may suggest inflammation or rib pathology. Vocal fremitus and tactile vocal fremitus should be assessed because they increase in consolidation and decrease in pleural effusion or pneumothorax. Tracheal tug, also known as Olivier sign, should be assessed. Inspiratory tracheal descent should also be noted. Palpation should also detect subcutaneous emphysema, which produces characteristic crepitus sensation. Parasternal heave indicates right ventricular hypertrophy. Palpable second heart sound may suggest pulmonary hypertension. Percussion. Percussion is the next step in respiratory examination and helps to assess underlying lung density and presence of air, fluid or solid pathology. Direct percussion is performed over clavicular region on both right and left side. Percussion is also performed over manubrium, upper sternum and lower sternum to assess underlying mediastinal structures and detect abnormal dullness or resonance. Indirect percussion is a standard method used in respiratory examination. Anteriorly, percussion is performed first on right and then on left side to compare both lungs. Chronic isthmus represents narrow band of lung resonance above clavicle. Percussion is then performed over infraclavicular region followed by mammary region to assess lung resonance. In axillary region, percussion is performed up to 5th rib and then continued to infraaxillary region between 5th and 8th rib. Posteriorly, percussion is performed over suprascapular, interscapular and infrascapular region to evaluate posterior lung fields. Area of right liver dullness is also assessed and normally this dullness moves downward by one intercostal space during inspiration due to diaphragmatic movement. Trough space is located on left side below ribcage and normally gives tympanic note due to presence of stomach. Tidal percussion is performed posteriorly on both sides to assess diaphragmatic movement during respiration. Cardiac dullness is also assessed. Right cardiac dullness normally lies approximately 1 cm lateral to right parasternal border. Left cardiac border corresponds to location of apical impulse. Superficial cardiac dullness represents area where heart is not covered by lung tissue. Shifting dullness may indicate presence of pleural fluid. Straight line dullness is seen in hydropneumothorax. Percussion tenderness may occur in rib fractures, infection or inflammation. Scordiac resonance is a special percussion note heard above pleural effusion due to compressed lung. Auscultation. Auscultation is the final step in respiratory system examination and helps to identify airflow abnormalities and additional lung sounds. Breath sounds are first assessed and may be normal, absent or diminished depending on underlying lung pathology. Bronchial breath sounds are abnormal breath sounds heard over lung areas, and these should be described based on their site and type. Types include tubular, cavernous and amphoric breath sounds. Post-tussive suction refers to changes in breath sounds heard after coughing. Added sounds should be identified. First, crackles. Crackles may be fine or coarse. They may occur during inspiration, early, mid, or late, or during expiration. Postussive crackles may appear after coughing and can suggest bronchitis. Wheeze is another added sound and may be inspiratory, expiratory, or both depending on airway obstruction. Vocal resonance refers to transmission of voice sounds through lung tissue. It may be increased or decreased depending on lung pathology. Different types of vocal resonance abnormalities includes bronchophony, where spoken words are heard clearly through stethoscope. Egophony produces a nasal or bleating sound when patient speaks. Whispering petrology occurs when whispered words are transmitted clearly through consolidated lung tissue. Miscellaneous sounds such as pleural rub may be heard in pleural inflammation. Additional clinical signs include Heimlich manner, succussion splash, cowing sound, scratch test, and DE spine sign, which may help in identify specific thoracic condition. Hum and mediastinal crunch is a crunching sound heard in mediastinal emphysema and occurs synchronously with heartbeat. After respiratory system examination, other systems should also be examined to identify associated complications or systemic diseases. In cardiovascular system, position of apex beat should be assessed to determine whether it is displaced or not. Heart sounds, first heart sound and second heart sound should be evaluated to determine whether they are normally heard. Pulmonary component of second heart sound P2 should be assessed because increased intensity may indicate pulmonary hypertension. The central nervous system, higher mental functions, cranial nerves, motor system and sensory system should be examined. In gastrointestinal system, abdominal examination should be done to look for any hepatomegaly, splenomegaly or ascites, which may occur in chronic lung disease, pulmonary or systemic infections. After completing history and examination, a structured final diagnosis should be made. First, anatomical location of disease should be identified, whether it involves right lung or left lung or both lungs and which lobes are affected. Next, site of pathology should be determined, whether disease is located in lung parenchyma, airways, pleura, pulmonary vasculature or interstitial tissue. Type of pathology should then be described, such as consolidation, pleural effusion or neoplastic disease. Probable etiology should be determined, which may be infective, neoplastic, inflammatory, suppurative or allergic. Finally, possible complications such as pulmonary or lung abscess should be considered.